Are you ready to elevate your expertise in the pediatric cardiology field? Welcome to the Pediatric Cardiology Fellowship, a premier one-year online program designed to equip you with advanced knowledge in the pediatric cardiology field. Our aim is to provide you with high-quality educational materials and up-to-date pediatric cardiology scientific knowledge delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is high quality, up-to-date, evidence-based, and well-structured. Why travel for training when you can learn from top pediatric cardiology experts online? Our program brings world-class instruction directly to you, no matter where you're located, through case-based discussions, Q&A sessions, virtual workshops, and personalized feedback. You'll receive the same high-quality education
that augment and complement your personal training,
all from the comfort of your home or workplace. Our pediatric cardiology program offers a comprehensive fellowship structured into 3 modules, 16 weeks each, with a total of 96 credit hours and in-depth training over 1-year period. Balancing work, life, and professional development can be challenging. Our Pediatric Cardiology Fellowship is designed with your busy schedule in mind. With self-paced learning modules and live virtual sessions, you can advance your skills without disrupting your clinical duties. This program allows you to learn and gain experience at your own pace. From mastering congenital and acquired heart diseases to specialized training in ECG, echocardiography, cardiac imaging, including MRI, diagnostic heart cath, electrophysiology and arrhythmia management, mechanical circulatory support, and cardiac critical care. You will develop the essential skills to manage children with various kinds of heart disease at any circumstances and healthcare setting. Upon completion, you'll earn an internationally recognized AACME accredited graduation certificate, helping you enhance your credentials, advance your career, and improve your patient outcomes. Join a growing community of pediatric cardiology professionals who have transformed their careers with this fellowship. Don't miss this opportunity. Take the first step towards mastering the pediatric cardiology specialty and transforming the way you deliver care to your sick children. Visit our program landing page and register to reserve your spot. Limited seats available. Don't miss your chance and register today.
Hello, everyone, and welcome to our World Institute of Critical Care and Emergency Medicine Pediatric Cardiology Fellowship webinar. We have a very special webinar today, and we are focusing on what's beyond the echo probe, and we are trying to unblock the heart with other cardiac modalities, including CT and cardiac MRI. We have great speakers today, Dr. Abdul Majid Al-Otay, Dr. Riyad Abu Zahr, Dr. Muhammad Hassan are the 3 main speakers, and our webinar organizer, Dr. Muhammad bin Muallim. And here is our calendar today. After this intro, Dr. Abdul Majid Al-Otay is going to talk about strategic use of CT, MRI, and angio. Then Dr. Riyad Abu Zahr will talk about the cardiac MRI evaluation for a rebirth tetralogy of Fallot. Then Dr. Muhammad Hassan is going to give the last speech about CT evaluation of pediatric patients with congenital heart disease. Again, Dr. Muhammad bin Muallim is going to master the discussion, and also he is going to help the speaker to answer the questions. And Dr. Abdul Majid Al-Otay, our first speaker, is a consultant pediatric cardiologist, and he is the head of the Saudi Pediatric Cardiology Society and head of Scientific Committee of Pediatric Cardiology Saudi Fellowship Program. And we have Dr. Riyad Abu Zahr, who is a consultant pediatric cardiologist at Jeddah. And we have our third speaker, Dr. Muhammad Hassan. He's a consultant pediatric cardiologist and advanced cardiac imaging at King Abdulaziz Cardiac Center, Riyadh, Saudi Arabia. Just housekeeping stuff here. You can press on show caption, so you can also see that transcribed lectures on your screen. If you want to do this, please enable this option in your screen. If you have any question or inquiries, you can put it in the QA box, and all attendees should receive their certificate of attendance by next week. If you are interested, if you haven't joined our online pediatric cardiology fellowship program yet, please do. We are going to share the application link, and please take advantage on this promo code webinar 10 to get 10% discount. With that, I'm going to let Dr. Muhammad bin Muallim to introduce our first speaker, Dr. Abdul Majid Al-Otay, and to moderate the session.
Thanks, Prof. Amr. Good evening, everybody. We are delighted to have an outstanding panel of experts today. They will guide us through advanced cardiac imaging beyond echocardiography. We will focus on cardiac CT and cardiac MRI and congenital heart disease. Our first speaker is our senior, Dr. Abdul Majid Abdulaziz Al-Otay. He's a senior consultant, pediatric cardiologist, and consultant in echocardiography and advanced cardiac imaging for both pediatric and adult patients with congenital heart disease at Prince Sultan Cardiac Center, Riyadh, Saudi Arabia. He is also a head of Saudi Pediatric Cardiology Society and the lead of the scientific committee of the Pediatric Cardiology Saudi Fellowship Program. He will talk today about the topic titled as Beyond Echocardiography, Strategic Use of Cardiac CT, MRI, and Angiography. Please note that Dr. Al-Otay is currently recovering from a recent respiratory illness. Despite this, he was really very keen to join us today, and we appreciate his commitment and kindly ask for your understanding should there is any minor interruption of his voice, so you know the background. Get well soon, Dr. Abdul Majid Al-Otay, and you can share your screen.
Okay, I would like to welcome everyone. Good evening by Riyadh time. Good time for everyone elsewhere. Thank you, Dr. Muhammad, Dr. Amr, for this kind introduction today about talking about beyond the echocardiography, where to go. So evolution of the cardiac imaging started a long time ago, 200 years ago, and it starts with the era of light. I call it era of light because this is the first time and was the only source of information about pathology is autopsy, which means directly observing the heart, also known as a post-mortem examination. It is highly specialized surgical procedure that consists of systematic examination to determine the cause or the manner of death, usually performed by pathologists. Despite being an old practice, long time ago, dating back to 17th century, it remains the gold standard reference for medical understanding. For us as a cardiac imager, we continue to rely on this fundamental principle, direct visualization of the pathology. A similar level of validation is achieved intraoperatively when the heart is directly observed by the surgeon, allowing a real-time correlation with finding from echocardiography, CT, and MRI. That's the reason we used to visit the OR and to ask a surgeon about his feedback and to see the heart by direct anatomical confirmation that will provide a powerful feedback and reinforcing the accuracy of our imaging interpretation and bridging the gap between the imaging and the true pathology. So still autopsy a long time ago, but still we do visit the OR to see our findings in the CT and MRI and echo. After that, era of X-ray, it was started 1896, when a new type of rays was generated by electrical discharge through a tube using induction coil. That was Will Conrad Roentgen, that was 1896. X-ray remains an important screening tool and essential before planning CT and MRI protocol. It provides a usual additional information. However, sensitivity and specificity for congenital heart disease remains 71 to 78%, even in expert radiology eyes. However, remains a very helpful tool. Ultrasound actually started a long time ago, 1920. However, it was non-civilian use in the submarines, Navy during the war. But the civilian use of the ultrasound started 1954 when N.G. Idler and his colleague Hertz, they were able to produce this machine, and they were able to show us the motion of the left atrium wall. That was 1954. So after that, or before ultrasound, actually before echo, the CAT started. Until the middle of 20th century, little was known about the pulmonary circulation. It was the pioneering work of Forsman, Conrad, and Richard. That was 1940s, when they were able to make the right heart catheterization, and with it, the measurement of the pulmonary arterial pressure possible. 15 years after, echo came. 15 years after CT scan for cardiac application. And early 1990s, we started to see the cardiac MRI. So this is the evolution of cardiac imaging. Now, we do believe that accuracy of echocardiography intracardiac anatomy is 96 to 98%. And it is a very good tool to evaluate the intracardiac and most of the extracardiac structure. With the anatomy, we can see also hemodynamic. The echo has rapid sampling rate. Thus, it is good to measure the systolic time intervals from the aortic and pulmonary valve by Doppler tracing. This technique has received the most use for detecting any hemodynamic disturbance. There is no other means available to measure it. So also we can evaluate the valvular stenosis, regurgitation. By echo also, we can perform a trans-esophageal echo. So the advantage, there is no window limitation, defining the tumor attachment, tumor extension, any vegetation, detecting the cardiac thrombi, monitoring the invasive or surgical procedure. And also we can do by echo a contrast study to see the hidden shunt, to see the coronary sinus, AV malformation. We can also study the myocardium to evaluate the motion of the myocardium in diastole and any restrictive physiology. Also by 3D, we can do more for the mitral valve if there is controlled heart rate. So we can see the motion of the mitral valve. We can see the source of regurgitation of the mitral valve by 3D. We can see also the artificial valve motion. And also we can do some quantification for the mitral valve, for the saddle shape of the mitral valve artificially. And we can also measure the LV in diastolic volume, LV in systolic volume, and still with trials to also evaluate the right ventricle volume. Still, MRI, echo is progressing. In the future, we might see a lot regarding myocardial contrast echo, speckle tracking, Doppler tissue imaging, real-time, three-dimensional echo. So it is promising year by year. We see more advanced characteristic of the echo tool. So if we use this a balanced approach to see where is the strength and where is the limitation. Echocardiography is an accurate, very rapid sampling rate, non-invasive, available, portable, superior for pressure and flow interaction, reliable correlation with invasively measured pulmonary pressure. However, we have some limitation in echocardiography. Some of the limitation regarding the patient-related obstacles, obesity, chest deformity, hyperinflated chest, echo equipments. You cannot compare old machine to up-to-date new machine. And also echo, we used to use like operator dependent. Lack of knowledge, you will not be able to interpret or to produce a nice hemodynamic picture. Lack of skills, you will not be able to produce a nice images to reach diagnosis. And you need a cognitive function of the operator, somebody to correlate the knowledge to skills and to see the cardiac monitoring to measure the saturation, upper lower limb, blood pressure, upper lower limb, and to correlate all together. Sorry. Also, ultrasound have weakness because ultrasound imaging based on number of assumptions. As example, ultrasound travel in a straight line, which is not right. All detected echo originate along the axis of the transducer. No, this is not right. All received echo are derived from the most recently transmitted pulse, which is not right. This is the reason we see dropout, we see like mirror image, and we some reaction that makes some confusion in the diagnosis. Also, by echo, with a poor alignment, we cannot produce a very good hemodynamic numbers. Most of our numbers based on the assumption. By echo, we cannot see detailed small structure like distal coronaries. We cannot see the precordium reaction. So tiny vessels, we cannot see it by echocardiogram. Most of our cases will reach diagnosis by echo. However, we have some limitation. We might lose the battle with echo. So after that, if we have cardiac disease, a complex one, and good history, good physical examination, good ECG, good chest X-ray, and we do echo, we repeat echo, we did not reach diagnosis. So where to go? Unfortunately, a long time ago, we moved from echo to cath. That was 2 decades ago. And we have to consider cath angio is an invasive procedure, radiation exposure, cost-effective, so foreign body inside the heart. Over the past 2 decades, there has been a noticeable shift toward the patient-centered approach in imaging selection. When the echocardiography is not sufficient to reach a precise diagnosis, clinicians increasingly choose the most appropriate advanced modality. With wider availability of these technology, CT and MRI across many hospitals, along with the growing expertise in performing the technique by technologists and interpretation by expertise cardiologists. So there is no excuse to go from the echo to the cath lab. So there is now a greater flexibility in selecting the optimal imaging tool for each patient. So we have to think about CT and MRI before moving to the cath lab. So this is my balanced approach. And this is the most important slides to talk about strategic role in selecting advanced imaging. So what does it mean, balanced approach? It is guided by the clinical question. What to select, to go CT, MRI, or angio. It is guided by the clinical question, not by the routine use or common practice. So it is based on 4 principles. Principle number 1, question first, clinical question first. So select the modality that answers the specific clinical question. What is the need? Are we looking for anatomy? Are we looking for function assessment? Are we looking for possible intervention? So define your question before selecting the tool. Rule number 2, maximize the yield. Choose the technique with the highest added diagnostic value. So I need to do this and that. And the questions might include volume measurements and anatomy. I'll go to cardiac MRI. I will not go for CT scan. I will not move the patient from CT to MRI to angio. No, try to maximize the benefits from that tool. Balanced risk benefit. Consider there is radiation in CT scan. There is sedation and ventilation in the MRI. There is procedural risk by angio. So you have to make this balance. Minimize the harm. Use the safest, least invasive modality without compromising the accuracy. So I consider this balanced approach based on the 4 principles is must before selecting the CT or MRI or not to go to angio unless you answer this question. So let me summarize it again. The best imaging modality is not the most advanced one, but the one that answers the clinical question accurately, safely, and efficiently. So this is the most important slide. So let us go for cardiac CT. Demonstrate the shape, the spatial relation of the great vessels, connections of pulmonary systemic veins, lungs, and airway. Advantage, very good for pure anatomical question. I'll send for cardiac CT. I'll send for coronary artery assessment by CT scan. CT scan as a roadmap re-intervention. CT scan for the vascular airway spatial relation. If there is airway compression, vascular ring. I'm looking also to answer the lung disease or airways patency or go for CT scan. Any extracardiac thromboembolic phenomena, pulmonary embolism, or go for CT scan. Why? Because high spatial resolution, shorter scanning time, fewer sedation, you don't need general anesthesia, minor risk for vaso-occlusive crisis, sorry, less artifact, and there's no issue with the bone, lungs, and airway. So I can add just one more thing for indication. MRI, if there is MRI candidate case, but the patient unstable or with intractable arrhythmia, the MRI is not available, or there is contraindication to go to MRI, I will go for cardiac CT. If it's an emergency situation, I will go for the cardiac CT for extracardiac structures. So examples of MRI, if we see like dilated right ventricle, right atrium, dilated pulmonary arteries, this patient came to us and he was treated as pulmonary hypertension based on very high RV systolic pressure, dilated branch PAs, dilated RA and RV, there was no shunt. But doing like CT scan, he was a little bit dysmorphic. Is he nonan, not nonan? So we did for him CT scan. We found like, as you see here, let me show you, where is my laser? Is it the pointer? So we see distal branch stenosis at the segmental and subsegmental, at the lobar, even at the side. By volume rendering, it is more clear here. If we see it more advanced in the segmental, subsegmental, a severe stenosis. So there's mechanical obstruction. So no benefit from antihypertension treatment. So you can see it here, very tight, segmental and subsegmental. So you have mechanical obstruction. It was answered only by CT scan. So this is one example. Other example, patient came to us, he's 18 years old, came with exercise intolerance. Found to be very high blood pressure, upper limb, no femoral pulses, and pulsatile abdomen. Whole abdomen is pulsatile. So there was severe left ventricle hypertrophy. Otherwise, the echo reported to be normal. So this is the echo. We can see very dilated ascending aorta arch, a reversal flow in the abdominal aorta. There was no aortic regurgitation. There's no collaterals at this level by echo, and no fistula. So there was no explanation. So we did for him cardiac CT. Sorry. Stop my pointer here. We did for him cardiac CT. We see that this is a rare congenital anomaly characterized by absence of the abdominal aorta, with systemic perfusion maintained through extensive collateral circulation. So we see his abdomen very pulsatile everywhere. Right flank, left flank, all are pulsatile because of this, a massive collaterals. So this is absent abdominal aorta, echo report to be normal. Also, in the beyond the hilum, left hilum and right hilum, we can see aneurysmal dilatation of the left pulmonary artery, and we can see a flattening of the bronchus because of this huge aneurysmal dilatation. For the aortopulmonary collaterals, our surgeon preferred to be a very selective angiogram by cath, in the cath. However, we do follow him like a roadmap, not to miss any vessels. So this is a roadmap. So our colleague in the angiogram, they will go for a selective injection, so it will be easy for the surgeon to evaluate. This case, the pulmonary atresia with bilateral ducti. It was impossible to see it at once by echo. Thus, we do these images. We come closer and closer to see the ducti, the right and left ducti. Also, this tool is an excellent tool to evaluate the relation of the airway to the arch. So we can see that all type of vascular ring in these examples. We can see the ring, absent ring here, and sling of the pulmonary arteries. We can also evaluate the absent ring by virtual bronchoscopy. This is by cardiac CT. You can do it by cardiac MRI, but with less resolution. In cardiac CT, we can see the trachea, we can see the esophagus, NG tube, so it is more clear. So all type of abnormal aortic arch with aberrancy here or there, we can see it by cardiac CT in axial, coronal, and sagittal, and also by volume rendering. So double aortic arch with a dominant right arch in this case. Other example, see it from different views. We can see double aortic arch with codominancy of both arch that encirculating the trachea. I'm sure Dr. Muhammad Hassan will show a very good, beautiful examples. This is an unusual cases. You cannot see it by echo. Right aortic arch with aberrant left brachiocephalic artery and left-sided PDA. You can see a truncus arteriosus with aortic arch interruption. Then you will draw it. This is by my colleague, Dr. Sharif. Next day, we will go to the OR to see it, direct observation in the OR, and to take an image for these pictures. So the branch pulmonary arteries, CT scan is considers the best. We can come closer and closer to see the stent. Is it in situ? The pulmonary veins, a scimitar, abnormal connections of pulmonary veins, infracardiac, total anomalous. You can show it by CT scan. And also you can see any abnormal findings in the lung, like this case with the dextrocardia and AV malformation everywhere. It's a macroscopic one in the right lung. Left lung is preserved. So this one also of the examples. You can also doing like a dynamic study. We call it hyperdynamic study for airway compression to assess the airway in relation to the great vessels. So with the dynamic protocol, we are evaluating the airway compression and what is the severity. So just to conclude the cardiac CT, high spatial resolution, short scanning time, fewer sedation, no need for general anesthesia, minor risk of vaso-occlusive crisis, less artifact, very good for thromboembolic phenomena. So very good for the vasculature and airway compression. However, radiation and radiation and radiation, there is reaction to contrast, limited field of view. You cannot do function or flow assessment. You can do function assessment, but you have to pay by more radiation and no tissue characterization by cardiac CT. So we might lose the battle also. So where to go? I will go to cardiac MRI. There is no radiation, natural contrast. You can do also a bronchoscopy, wide field of view, no influence of air, bones, or scars, unlimited choice of imaging plane. So you can do everything by cardiac MRI. So you can evaluate the right ventricle, left ventricle. You can measure the RV in diastolic pressure, LV in diastolic pressure accurately by cardiac MRI. You can see also that regurgitant jet. You can apply stacks for the in two orthogonal planes for the left ventricle, right ventricle. At the end, you can measure from the base to the apex the in diastole and in systole. At the end, you can show the accurate ejection fraction. You can evaluate also the myocardium to assess the myocardium contractility and torsion. By cardiac MRI, you can evaluate the flow in systole, in diastole, and to see the pattern of flow, the resistance, the compliance, the elasticity, not only in the major proximal branch BAs, but also distally, segmental and subsegmental. By cardiac MRI, you can evaluate the whole body. As example, if you have Kawasaki disease and you are expecting aneurysm, so you can do a simple contrast amount. You can show the whole body in one cut. So this is one of the advantage of cardiac MRI. So not that very high resolution, but at least you can detect the pathology. So again, the balanced approach, MRI is an excellent for anatomy, wide field of view, coverage, multiple imaging plane, no influence of air bones, good for blood flow and volume, for contractility and function, tissue characterization. However, it has limitation. Little bit sophisticated, little bit takes long time, needs sedation and general anesthesia, more artifact, issue with the pacemaker, old pacemaker, lower spatial resolution, limited for the lung and airway. So we might lose the battle also by MRI. So let me conclude, please. So echo or CT or cath or MRI. So by history, cath, then echo, CT, MRI, but we don't go by history. By the most commonly used, echo to the cath lab in some centers, then CT, then MRI, which is not right also. By safety, echo first, more safer, then cardiac MRI, CT considering the radiation, and the cath lab. This is an invasive procedure. So this is the balanced approach. Let us take that image, that message again. The best imaging modality is not the most advanced one, but the one that answers the clinical question accurately, safely, and efficiently. So where to go? Echo, then echo, then echo, then echo. Do it yourself. Ask your colleague to do it. Doesn't mean he's better than you. At least you did the 90%. He's relaxed to answer the remaining question. Or the expert sonographer. Use that transesophageal, under sedation, give contrast if you need it. So where to go? Depends on the availability. Indication versus contraindication. Strength versus limitation. What is the question exactly? So consider the safety issue also. And if there's any possible intervention, go to the cath lab directly. If there's small vessels needs selective angiogram, go to the cath lab immediately. And if there is bone vascular resistance, you need an accurate measurements, go to the cath lab directly. Otherwise, send all your patient after echo to the cardiac MRI, unless cardiac CT scan is the strongly indicated. Don't forget also the request of our cardiac surgeon. If he say, I need CT, go to CT. If he said MRI, MRI. We do respect because he's the one operating. Thank you.
Thank you very much, Dr. Ratey, for this interesting topic. You gave us a lot of keys. Now we'll move to the second speaker, Dr. Riyad Abu Zahar, consultant pediatric cardiologist and cross-sectional imager at King Faisal Specialist Hospital and Research Center, Jeddah, Saudi Arabia. He will be presenting CMR evaluation of repaired tetralogy of fellow.
Okay, good evening, everyone. Can you hear me?
Yes, Dr. Riyad.
Okay, great. I would like to thank the organizers for inviting me to speak about cardiac MRI evaluation of repaired tetralogy of Fallot. Let me just open my pointer. I have no relevant disclosures. So in the coming 20 minutes, we will go over how can MRI be of use for us in long-term follow-up of tetralogy of Fallot, and how it can help us in deciding when to do or replace a pulmonary valve. We'll go over RV sizing and function, pulmonary regurgitation, stenosis, suitability and sizing of the RVOT, talk about scars and adhesion at the end. Just before we start, I just want to emphasize one thing is, as Dr. Abdelmajid mentioned, each modality has its uses. And in tetralogy specifically, we sometimes rely on CT scan, mostly pre-op, if there's a question not answered by echo, or mostly in the post-op short term, if there is issues or pulmonary artery branching, etc. And these two will not be covered outside the scope of this talk. We're going to focus mainly on long-term post-op imaging. So common sequelae after tetralogy repair includes pulmonary dysfunction, and that involves regurgitation, stenosis, or both, RV dilation, main and branch pulmonary artery stenosis, if there is any RV residual defects such as ASDs, VSDs, and RV outflow tract aneurysms. Some of these sequelae are associated with adverse outcomes, such as LV dysfunction, ventricular tachycardia, white QRS, RV fibrosis, etc. Now, when is the optimal time to proceed for a pulmonary valve replacement? And cardiac MRI is the investigation of choice to help us determine the best time for PVR, I'm going to call it pulmonary valve replacement, and whether it is best to be done by percutaneously, by cath, or we need to do it surgically. And this is a recent paper in JACC 2024, a study about more than 200 patients that has found that the younger age, when you put a pulmonary valve replacement, and the smaller the diameter of that valve, both of these are associated with reduced durability of the valve that you place in the first 10 years. So maybe some might think, why don't we put the valve very early and stop the regurgitation? The study showed that this is probably not the best approach. And this is from the AHA guideline in 2024, also in circulation. And it tells us how to do surveillance for asymptomatic tetralogy patients, including exams, clinics, ECG, echo, Holter, etc. And of interest for us here is MRI. The recommendation is to start baseline MRIs at 12 years of age in asymptomatic patients and repeat every 4 to 5 years. The AHA and ACC in 2019, most of you might be familiar with this slide, have released guidelines also for when to place a pulmonary valve in repaired tetralogy in asymptomatic patients. And those have included if there is a mild to moderate RV or LV dysfunction, severe RV dilation, if we have an end diastolic indexed volume of 160 or an end systolic index volume of 80, or twice the size of the RV compared to the LV. If there is RV systolic hypertension, or obviously symptoms. Now, we've been using this for several years, but recently there is even more criteria have been added, as shown in this AHA guideline paper, also from 2024. As you can see here, if we follow in the middle, we have new risk criteria. If you have 2 of these risk factors in asymptomatic patients, we consider placing a pulmonary valve. And those include some of the indicator risk factors or risk score more than 3, and those are on the left. Age of the patient, obesity, the type of the conduit, and a newer marker, which is the GFI, which is biventricular global function index. This involves the end diastolic and end systolic volumes of both ventricles as well as the mass. And we do it for both the right and the left. And this is a recent indicator that can be used for this. Other newer risk factors also, if the RV ejection fraction is less than 46 by itself is one risk factor or one criteria. The depressed LV function less than 50 EF, and if the others are not new, which is RV systolic hypertension. So let's move on and see how can MRI help us. So let's start with RV sizing and function. This is a 4-chamber cine image by MRI, and it gives us a subjective idea on the size of the right ventricle. My pointer is in the right ventricle, and this is the right atrium. Depending on the physiology of the RV, the right ventricle might be volume loaded, pressure loaded, or both. Now, in order to quantify the right ventricular volumes, we perform a stack of short axis cine images from the base down to the apex of the heart over multiple slices and over one cardiac cycle, one heartbeat. And this will allow us, when we contour the end diastole and end systole, we will get end diastolic volume and systolic volume of the ventricle, both right or left, stroke volume, the ejection fraction, the mass, and obviously we can index those to body surface area to get the EDVIs. Now, rarely, as Dr. Abdelmajid mentioned, sometimes we cannot do MRI. For example, if you have old pacemakers or epicardial leads, etc. And in this situation, cardiac CT can help us and can provide almost the same information. But this is an example of one. This is a cine CT over a full cardiac cycle. We can get all the volumes. However, this will be on the expense of much more radiation than what we usually use in regular CTs in children. Next, we can interrogate the tricuspid valve. And tricuspid regurgitation is considered also one of the determinants of whether to go for a percutaneous valve replacement or a surgical valve replacement. If you have, for example, a significant tricuspid regurgitation, and for example, more than 20%, and the valve needs repair, then we might send the patient for surgery to have both of procedures done at the same time. Moving on to pulmonary blood flow and assessment. To measure pulmonary blood flow or regurgitation, we use a special technique in MRI called phase contrast imaging, which provides the forward and the retrograde flow per heartbeat. We can prescribe the plane that we want, for example, here in the main pulmonary artery. And then we contour, we draw a circle around the blood vessel in cross-section. And the resultant image on the top right would be the flow analysis curve, flow per beat. This is, for example, the forward flow. And in diastole will be the retrograde flow. Then if we divide the retrograde by the forward flow, we will get the regurgitant fraction. And classically for the pulmonary artery, less than 20% is considered mild regurgitation, 20 to 40 is moderate, and more than 40% is severe regurgitation. Likewise, we can quantify the flow in the branch pulmonary arteries, the right and the left, and obtain a differential pulmonary blood flow, similar to a perfusion scan, but the advantage is that there's no radiation, no injection of radioactive materials, etc. By comparing aortic and pulmonary artery flow, we can calculate the QPQS ratio and identify any residual intracardiac shunts, such as an ASD or a VSD, etc. And according to the recent guidelines, more than 1.3 QPQS in tetralogy as a residual lesion is one of the risk factors that help in the decision making. Next is sizing and suitability of a percutaneous intervention. We can assess that by focusing on three main things: the RVOT morphology, and the RVOT or pulmonary artery sizing, and the risk of coronary artery compression. We're gonna go over these in more details. First, RVOT anatomy. We can assess that by regular 2D cine. This is an example of a pressure and volume loaded right ventricle. As you can see in these images, there is pulmonary regurgitation and there is pulmonary stenosis at the same time, and an aneurysmal pulmonary artery. The images on the left is, these both images are for the same patient. The image on the left is the RVOT, right ventricle outflow tract, in a sagittal oblique view. And the image on the right is the same RVOT, but in an right anterior oblique orientation. Here you can see all the parts of the right ventricle: the inflow, the body, and the outflow. For more definitive evaluation of the RVOT branch pulmonary arteries, we resort to 3D imaging using contrast, enhanced MR angiography with administration of gadolinium, which is the MRI contrast. This will allow us to perform accurate measurements of the RVOT and the branch pulmonary arteries, and also do volume rendering, as you can see on the right. And this will be very useful to our non-imaging colleagues to appreciate the anatomy. Now, a problem we face in this MR angiography is that most of the sequences we have are not gated, meaning that this image that we acquire, we don't know where is it in the cardiac cycle. Is it in systole, in diastole, in between? We're not sure. And is it important to know? Well, the answer is yes. It's important to know where our measurements are done in systole or diastole, because it has been shown that the RVOT and the pulmonary artery dimensions, it change considerably throughout the cardiac cycle, and up to more than 20% change between systole and diastole of the same measurement at the same level. So for that, we resort to other advanced techniques of imaging, such as EKG-gated MR angiography. This is an example of one. When we gate with ECG, we can image in mid-diastole or in end systole. This is a technique called 3D IR flash, and it's respiratory navigated and ECG triggered. As you can see, we have better spatial resolution and better blood pool homogeneity. We can improve this further and do what we call a 3D whole heart technique. This is without contrast, but also ECG gated and respiratory navigated. And we can see clearly the pulmonary arteries, the branches, but also we can see the coronary arteries, as you can see in these images here. All right, one word about calcium and calcification. MRI is probably not the best imaging modality to look at calcium. These are CT scan images, and calcium on CT will appear very bright, as you can see here, very white. Also, likewise, stents will appear very bright, as you can see in the image on the right, bilateral stents. Both of these, an MRI is not very advantageous. Calcium will have a void signal. It will be very dark or black on MRI. And also stents, depending on the type, will give also susceptibility artifact, and you will see black. And it might be difficult to evaluate intravessel inside the stent. The next is RVOT sizing. We try to do measurements in general in end systole, because as you can see between these two images, the systole dimensions, as I mentioned earlier, are larger. We perform that by a technique called double oblique technique. We align the crosshair in the long axis of the RVOT in two orthogonal planes, and we'll get the resultant as a cross section in both. And then we perform measurements. And this has been studied in several studies, the effect of measuring in systole or diastole, or without gating, just in angiography. And it has been shown that the measurement, as you can see on the bottom right in systole, is much significantly larger than diastole or angiography. and the measurement in systole had the closest agreement with the cath measurements. In certain challenging cases, we can do 3D printing because we have, as you can see, different morphologies of the RVOTs. And depending on the morphology, some of them might be favorable for a valve, some of them might not be. And this is also just to show that the pulmonary artery or the conduit in systole is larger, denoted by the green, and the actual RVOT, meaning muscle below the valve level, actually goes smaller. So there is real dynamic differences between systole and diastole. If you don't have 3D printing technology, we can just do virtual reality and just on a software or a computer try to place a valve and see if it works. In certain cases, when the RVOT is very large and dilated, MRI regular valves might not be enough. So, for example, we need to use certain valves such as the Harmony valve, and for this, the company requires, at the moment, CT scan. Coronary artery compression, the main and most common concern is compression of the LAD. And as you can see in the image on the left, this is axial orientation, and this is the LAD in long axis. And this is the same patient, but in sagittal. This is the LAD here, the circle behind the pulmonary trunk. And this is a CT scan here, but just to show you that in diastole, this coronary artery, there is a space between it and the pulmonary trunk. But the same patient in systole, that space is completely obliterated, and the pulmonary artery is touching the coronary. So if you're planning to put stents, you have to be concerned here. Now, the most important risk factor for coronary compression is the proximity, the closeness of the coronary artery to the conduit. This has been studied in several studies. If the distance is less than 2 millimeters, this is high risk. If more than 5, it's usually low risk. Two important distances are the shortest orthogonal distance from the coronary to the conduit, this in yellow. Again, if it's less than 2, it's significant. And the red distance, which is the distance from the coronary to the narrowest RVOT, if it is less than 13, also carries a higher risk of compression of the coronary. As you all know, in tetralogy, there might be also coronary anomalies up to 3-4%, which is LAD arising from the right pulmonary artery, as shown in here, and taking a pre-pulmonic course anterior to the pulmonary artery. Next is myocardial scar. We do this when we evaluate older patients with tetralogy. So if you're doing a 12-year-old, maybe you don't really need, but maybe beyond 15 or 20, usually we always do it. If we are giving contrast, we look for fibrosis. And it has been shown that right ventricular fibrosis is a predictor of arrhythmias in patients with repaired tetralogy of Fallot. This is work done in the Royal Brompton in London. And it has shown that fibrosis is in either ventricle as associated with ventricular dysfunction, exercise intolerance in repaired tetralogy patients. Okay, finally, a word on adhesions. When we do the MRI, we don't know if the patient is going to go for a cath-based pulmonary valve replacement or surgical. So in all patients, we try to look for adhesions. If the patient has significant retrosternal adhesions, to alarm or alert the surgeon that they need to take precautions. This is a technique that can help us to do that. This is real-time cine images while asking the patient to take deep breaths in and out. And if you can appreciate, as you can see in the cine on the right, if there's deformation of the right ventricle, and the RVOT changes shape and remains stuck to the same point on the sternum, then this suggests that there is significant adhesions. And then we tell the surgeon if they're going to go for surgery, maybe you should cannulate the groin and go on bypass before doing a sternotomy to avoid structure laceration to the ventricle or the pulmonary artery, etc., etc. So in conclusion, I hope I've shown you that cardiac MRI is the imaging modality of choice to assess timing of pulmonary valve replacement in asymptomatic repaired tetralogy of Fallot patients. and the suitability of percutaneous versus surgical valve implantation. And thank you for your attention.
Thank you, Dr. Riyad, for this great and informative lecture about the role of, or one of the important role of cardiac MRI. We know that cardiac MRI had different rules also, other rules like shunt quantification, functional evaluation, and different congenital heart diseases. Now we'll move to another modality of advanced cardiac imaging, cardiac CT, with our last speaker, our colleague, Dr. Muhammad Hassan, consultant pediatric cardiologist and advanced cardiac imaging specialist at King Abdulaziz Cardiac Center, Ministry of National Guard Health Affairs, Riyadh, Saudi Arabia. He will give us a talk about CT evaluation of congenital heart disease.
Good evening, and thank you for the World Institute of Critical Care board members for their invitation to discuss the basics of advanced cardiac imaging in congenital heart defect. Especially in this part, we concentrate on the cardiac CT with common and uncommon examples. The comprehensive imaging assessment of cardiac anatomy and physiology is the key component in the management of patients with congenital heart defect. Selection between echocardiography, cardiac CT, and cardiac MRI based on what questions we need to answer. Several questions should be asked prior selection of imaging test. The first question, does the study indication justify the risks? As the radiation and the contrast exposure is part of the risk in the cardiac CT, sedation and anesthesia also playing a major role. Medication for heart rate control in another risk in the cardiac CT. Also, we need to compare between the diagnostic modalities available and to ask ourselves about the information impact on clinical management of the patient, asking ourselves if we are checking for the spatial relationship, so cardiac CT will be the best choice, while if we are assessing volume, function, flows, the cardiac MRI will be the best. If we are looking for intracardiac lesion, the echocardiography will give the answer. For optimal imaging setting for congenital heart defect, we need to check for availability of alternate imaging modalities. Close collaboration and communication between the referring physician and the cardiac imaging staff is one of the crucial points. All patient clinical information, including prior imaging finding and reports, should be reviewed. Scan protocols should be designed and adjusted to extract the maximum clinical information at the minimum procedure risk. In addition to the above point, expert technologists in cardiac imaging and nursing support, plus post-processing workstation, high-speed network, and immediate availability of resuscitation team and equipment for safety, and easy access to pacemaker programming. All those points are important for optimal imaging setting for congenital heart defect. For cardiac congenital heart defect, there is a specific knowledge which is required. Anatomy and physiology of the natural and repaired congenital heart defect, surgical procedures and catheter intervention and the material that used in the surgical procedures, common residual hemodynamics, and also the indications for re-intervention based on different international societies' guidelines, normal coronary anatomy and congenital anomalies, basic ECG knowledge and arrhythmia recognition. For the CT technique, we need to know about the radiation physics, radiation dose reduction, individualized scan planning, post-processing methods, standards for reporting in congenital heart defect, cardiac CT training, especially in the congenital heart defect part, scanning principles and scan modes, contrast protocols adjusted for both patient size and cardiac pathology, treatment of minor and major contrast reactions. The important question, when to call for cardiac CT in congenital heart defect. And the best example are the extracardiac vasculature, like pulmonary arteries, pulmonary veins, systemic veins, aortic arch and its branches, airway vasculature, spatial relationships. We'll shed a light on each example of those, starting with the case of tetralogy of Fallot. And echo defines all the components of tetralogy of Fallot. However, the CT evaluation of pulmonary arteries, collaterals, using that and in objective methods like Magor ratio, Nakata index for quantification of degree of pulmonary hypoplasia, in addition to looking for association like right aortic arch and its branches, abnormal coronary arteries, persistent left SVC. And we'll take here example for that. This is an axial cut for the CT, and you can appreciate when we are going from superior to inferior. You can see here, this is the right aortic arch, which is significantly dilated. And then you can appreciate this stented right ductus arteriosus. And then when it comes at this level, you can appreciate the pulmonary artery, which both of them are small. And this is hypoplastic, infundibular hypoplastic main pulmonary artery. Reaching here to this part, this is the aorta override the septum, and this is large VSD. And here at the posterior aspect, you can see there is an coronary sinus which is dilated due to the persistent left SVC. So looking to this axial cut, you will see the whole structure for and the whole component of the tetralogy of Fallot. While checking this reconstructed image, you can appreciate this an objective method for assessment of the pulmonary arteries in comparison to the descending aorta, and if you compare it to the significantly dilated ascending aorta. From this oblique view, you can appreciate here hypoplastic main pulmonary artery and infundibulum in this image. And checking it from the coronal view at this part, you can appreciate here clearly this is significantly dilated ascending aorta overriding the septum, and beside to that dilated ascending aorta, there is hypoplastic. You can see here there is hypoplastic main pulmonary artery, and if you can move more, you will see this is small pulmonary arteries, and there is stented right ductus arteriosus. Again, if you look to this image in this reconstructed 3D image, you can see there is bilateral SVC, and there is significant dilatation of the ascending aorta and discrepancy between the ascending and descending aorta. And this is the stent at this part, and those are the pulmonary arteries which are small in size. Not only that, but if you look to it from the intracardiac, you can appreciate here, this is from the posterior aspect, those are the pulmonary vein, this is the ascending aorta, those are the pulmonary arteries, and you can look to the calibers of those pulmonary arteries. Another patient here, we can look to it, this is a 3 month with the tetralogy of Fallot. However, this time there is left aortic arch. This is the left aortic arch, and those are the confluent pulmonary arteries, hypoplastic pulmonary artery. And here there is juxtaposed appendages, which is both appendages located on the right side of the ascending aorta. And you can appreciate here hypoplastic main pulmonary artery. And not only that, but also if you look to this clips, which is catched during the OR, those are the 2 appendages located on the right side of the ascending aorta. Another patient of tetralogy of Fallot, but this time in association with complete vascular ring, because if you look here, you can appreciate clearly in this image, this is from the anterior aspect, and then looking from the posterior aspect, where here there is left aortic arch with the circumflex descending aorta, And at this point, you can see this is the diverticule of Cameron, and this is the apparent right subclavian. If you look more here, you will appreciate in this one, this is right ductus arteriosus, which is complete the vascular ring at this area. And if you look to this reconstructed images, the ascending aorta arch, descending aorta, and then this is the diverticule of Cameron, and this is the right ductus arteriosus completing that ring. Another example, which is a tetralogy of fellow with absent pulmonary valve, echo again will show the anatomy from intracardiac and the presence of dilated right pulmonary artery. While in this view, you can appreciate in this coronal view, there is significant dilatation of the right pulmonary artery. However, when it comes here, you catch that there is a disconnected left pulmonary artery, which is supplied from the adductus arteriosus that come from the base of the innominate artery. You can see it here clearly in this image. And that dilatation of the right pulmonary artery lead to compression of both left and right main bronchus. And this is very clear here. You can appreciate the spatial relation between the airway and the dilatation of the right pulmonary artery. For the truncus arteriosus, again, echo will give you the answer for the intracardiac. You can see here, this is the left ventricle, right ventricle, and the truncal valve override that VSD. And here there is part of the main pulmonary artery. However, when we check by the CT before that, you can see here, this is the right pulmonary artery, and even by color, this is the right pulmonary artery. The left pulmonary artery missing in this views. Digging more here, you can see this is the arch, and this is the ductus arteriosus supplying that disconnected left pulmonary artery. For more clarification in the same patient, we check by the CT. This is the right pulmonary artery, it's good size. However, the distal pulmonary artery here seen with the constriction between the left pulmonary artery and the ductus arteriosus, and there is no continuation between the left one and the right one. And you can appreciate here in this image, this is the ductus arteriosus, which comes from the underneath of the aortic arch, supplying that distal left pulmonary artery, and there is a constriction here between the LPA and the ductus arteriosus. Using the 3D reconstructed image in this one, you can appreciate here very clear. This is showing a truncus arteriosus. However, not only that, but disconnected left pulmonary artery, which supplied from the ductus arteriosus at this point. And for this reason, we can go beyond the 3D reconstruction and see from cut through and going inside the heart and showing here very clearly the pulmonary arteries are originated in different levels. One coming from the ascending aorta immediately above the truncal valve, and the other one is coming from the underneath of the aortic arch supplied by the ductus arteriosus. Another case here showing this is like a single trunk, and here one valve we are seeing it at this level. However, this is a VSD, those are the two ventricles, but is it a truncus arteriosus? No, because when we look here, this is the hypoplastic ascending aorta, which is just supplied retrogradely the coronary artery. And for more clarification, we did the CT, and here we are looking from the inferior going up, and here we can catch the pulmonary veins going to the left atrium, and that one is the right atrium. Then this is the ventricular level, this is the VSD, and then this is the trunk, which is give rise to both pulmonary arteries. Beside that trunk, there is small hypoplastic ascending aorta, which is clear in this coronal view. This is the hypoplastic ascending aorta supplying the coronary artery in a retrograde fashion. and you can appreciate it here very clear in this image. This is thread-like, which is the hypoplastic ascending aorta, while the other trunk giving supply to the ductus arteriosus and supply to the both pulmonary arteries and descending aorta. And also you can see it here in this cut through, in which you can appreciate this is the two ventricle VSD, and this is the trunk, and this one is the small hypoplastic ascending aorta that supplied the coronary arteries. This is another lesion, which is the hemitruncus, here the ascending aorta, and this left pulmonary artery coming from the pulmonary trunk, and we can appreciate it here from this coronal view. You can see clearly this is the ascending aorta, which is give rise to right pulmonary artery, while the left pulmonary artery is a continuation of the main pulmonary artery. Also, you can appreciate it from cut through here. You can see clearly this is the left pulmonary artery and this is the right. Each one is coming from different source. This will lead to pulmonary hypertension, especially in the right lung. This is a case of pulmonary atresia, and in this sweep you can start, which is started from the atrial level until you see the outlet here. You can see only single trunk, and that single trunk giving rise to the ascending aorta. There is no main pulmonary artery in this clip. However, when it reaches to the pulmonary artery level, you are seeing those both pulmonary arteries are supplied by ductus arteriosus. When it comes here in this views, this is the two ventricle and then the contrast streaming to the ascending aorta. Then you can appreciate here there is a ductus arteriosus, which this ductus arteriosus is tortuous and coming from underneath of the aortic arch, then supplying both pulmonary arteries. Another example here, you can see this is from superior aspect. This one is showing ascending aorta, and here there is a stump of the main pulmonary artery, and those are the pulmonary arteries. However, in this unique case, this ductus arteriosus with a dual channel and dual opening to the aortic part, and this is very important for the interventionist to know which channel he will use, the big one or the small one, and which one is suitable to put the stent inside. For the pulmonary venous, the pulmonary vein, usually this is the crab view, the normal, which is mimicking the crab. And here, this is from the CT, looking from the superior posterior aspect, showing the all pulmonary veins. Then when you check for the abnormal pulmonary vein, like total anomalous pulmonary vein, this is a supracardiac type. You can appreciate here in this view, all the pulmonary veins joining the vertical vein and then going to the innominate vein, and at the end to the right SVC, and here again from the anterior aspect, while this one from the posterior aspect, looking to the all branches of the pulmonary vein going to the confluent and then joining the vertical vein to the innominate vein. This is another example for a vertical vein going down in this one. This is the vertical vein, which is come here going down and then draining down, and you can see it and appreciate it in this 3D reconstructed image, which is very clear here, the vertical vein going and joining infracardiac at this case. Not only that, but also by using the CT, you will discover this patient with the right isomerism, because in this image you can see this is bilateral right bronchial tree. For the sinus venosus, this is an echo showing that overriding of the SVC to the interatrial septum, and here by the CT you can appreciate the pulmonary vein from the left side to the left atrium, right one to the left atrium, while the right upper and the right middle going to the SVC. Not only that, but you can check inside and you can look to the defect from inside here, and you can see This is the right atrium and this is a defect. And this is very important for surgical repair, in addition to if you need to do like stent for that one and use an intervention instead of the surgery. The systemic venous abnormality, this is bilateral SVC, but not only that, this is here, this SVC is overriding the interatrial septum, and this is, in this case, there is a sinus venosus defect in addition to the bilateral SVC. And you can appreciate it here very clear in this image. This is a neonate with a pulmonary atresia, and firstly, when echo done, we mistake this is like a right pulmonary artery. But when we did the more imaging here, we can see this is an erythro-aortic innominate vein in a case of pulmonary atresia. And this is another example for erythrocardiac innominate vein, which is very clear here. For the arch anomalies, we are discussing either patency obstruction like this one, or if there is an interrupted aortic arch in this case, or aortic arch geometry issue like the aortic tortuosity syndrome, or the arch branches like the apparent one, or here the isolated branch in which that isolated branch would be supplied either by the ductus arteriosus or retrograde from the vertebral artery. So for the obstruction, this is the case, and here the echo, there is narrowing at this part, which is very clear in the cardiac CT, and this is important for the surgical planning, in which the surgeon will do like end-to-end anastomosis, so he will know exactly where that area need to be cut and anastomosed. This is a case of hypoplastic aortic arch in which the surgeon need to do reconstruction. So the whole arch is hypoplastic. This is another case with the interrupted aortic arch, and we will go quickly through the echo, and then this is the CT in which there is an interrupted aortic arch type B and apparent right subclavian in which all the four limbs blood pressure will be equal, and you can see clearly here only the carotid coming from both carotid coming from the ascending aorta. Abnormal geometry in which echo will be very difficult. So for that reason, if you compare the echo images to the CT images, you will see how those CT images showing the complexity of this aortic arch tortuosity, and its branches also is significantly tortuous. This is example of aortic arch branching, but an abnormality of a vascular ring. This case is the unique because it's incidental finding in 68-year-old. And thank you for your attention. And this is our group in the KACC. Those are the pediatric cardiology advanced imaging team.
Thank you, Dr. Muhammad, for this really informative, well-illustrated presentation and lecture. Now time for question. You can send your questions. I will start with one question here. Let me just, the question is to Dr. Riyad. Dr. Riyad, can CT or cardiac MRI add a new for patient who has like bundle branch block or BVC if echo is normal?
Yes, we see this more commonly in adults, I want to say, but also in children. So if you have a normal echo, but for example, patient with PVCs or arrhythmias like VTAC, etc., many times the electrophysiologist would like us to map out if there is an area that where the arrhythmia might be coming from. And for this, we can use MRI by doing scar imaging. So we do late gadolinium enhancement. And sometimes if you find, for example, a focus in the left ventricle or the right ventricle, then the electrophysiologist will try to go after that focus in the EP study and try to isolate it and do cautery around it, etc.
Yes.
Now, for CT, in general, if the echo is normal, the yield is low, but in the adults, they would also do a coronary CT to make sure the coronaries are normal, not ischemia causing, for example, PVCs.
Thank you, Dr. Riyad. And I think maybe I can add, like also in cardiac MRI, we do see also the what's they're calling the cine movement of the LV, RV, and RVOT as well, beside the gadolinium enhancement evaluation. Dr. Al-Utay, one more question. If we compare the old CTs or old era and nowadays, what do you think about the safety of radiation? Is it okay if we move or send patient to cardiac CT nowadays, or do we need to worry or not? That's the question, I think. Yes.
Yeah, I agree with you. Yes, this is actually the radiation dose dramatically and significantly reduced by adding more slices. The first machine I trained on, that was in Toronto, it was 16 slices. Nowadays, 280s, so we need 520 slices, dual source. So yeah, reduction of radiation significantly allow us to get low threshold to deal with the cardiac CT cases. We do welcome a lot of cases, but not for academic purpose, but at least our threshold will be low to accept any case for non-clear echo to show the anatomy.
Thank you, Dr. Abdul Majid. Any more question? Anyone can want to ask? Okay, with this we can conclude. Thank you for your attendance. Thanks to the speaker. Thanks for the attendance also. Appreciate your time. Wish you all the best. Thank you from my side as well.
Thank you so much, Dr. Muhammad, Dr. Abdul Majid, Dr. Riyad, and Dr. Muhammad Hassan for this fantastic webinar. All our attendees should receive their certificates of attendance by next week. And by tomorrow, you should have the link of our YouTube recorded webinar. So we will be in touch. We'll share with you the link. And please, if you are interested to join our online Pediatric Cardiology Fellowship, please feel free to join. We already shared the link in our chat box. If you have any question, you can contact me or contact any of our board member, and they will be in touch. And again, thank you so much, and we'll see you in our next month Pediatric Cardiology webinar. Bye.
Thank you. Bye.
Mhm.
Thank you.